right, next up, I'm very excited to introduce my friend and colleague, Dr. Mario Castro. He's an assistant professor of CT surgery at Children's Hospital of Pittsburgh, and he'll be speaking to us today about pectus management in patients with familial aortopathy.
Okay, good morning, everybody. Welcome to the Aortic Symposium, Pittsburgh. I would like to say to the committee, thank you for the invitation for give this talk. The management of Pectus excavatum in all these kids with the with familiar aortopathies. So first, to know we're gonna talk about the chest wall deformities and the relationship about the patients with have a aortopathy, the generalities of the chest wall deformities, and also the implications for the chest wall reconstruction during aortic surgery. We need to understand that the pectus deformities can be a pectus excavatum, a pectus carinatum, that's what they call the pigeon chest. And between the general population is around the 0.8% of the population. On the Marfan syndromes can be up to 70% have a kind of chest wall deformity. Also, there's some associated other morbidities of this disease that can be a psychological distress on the patients, and also a lot of skeletal deformities like scoliosis. We need to remember that some of these genetic disorders that has collagen tissue disorders that they have some aortic disease. They also have some skeletal disorder like Loeys-Dietz syndrome, Marfan syndromes, and you can see like in this slice. We need to understand that the most common chest wall deformity is the pectus excavatum. Probably 1 of 800 children we will have a pectus excavatum. Is more predominant in males. And 90% of the pectus excavatum is 90% of all the chest wall deformities. And they have a scoliosis accompanied with a scoliosis of 20 to 30%. There's a family history of pectus excavatum, only around 40% of the patients. So pectus excavatum is seen in 2/3 of the patients with Marfan syndromes or related connective tissue disorders. Now, what are the most common symptoms that these patients complain when come and see us to get a pectus evaluation? Usually they have shortness of breath, exercise intolerance, chest pain. Some kids complain about orthostatic hypotension that's related when there's important compression on the RV. Some they have tachycardia, and most of the chest wall deformities, the progression during the puberty. So usually when they're between the 13 and the 18 years old, when they start growing and they spike the growing, that's when they increase the pectus excavatum. Also, all these kids complain about the poor body image, and that can be also one of the considerations for the operation. When we do the full evaluation, we always do like a history and physical examination, family history, if there's any medical history about any collagen tissue disorder. And the other one, we can do exercise tolerant tests, and the image studies are the most important. CT scan, can be cardiac MRI, and the echocardiogram. Usually, we don't do pulmonary function tests because most likely they're going to be on the normal size, they're going to be normal probably on the lower end of the curve, but very rarely they are abnormal. So most likely the most common diagnosis is the cardiac MRI, compression of the heart, and the CT scan. And the most important thing is for the workup, we send everybody to physical therapy. That's very important to work on the posture and help a lot of the spine work on the pectoral muscles and also the dorsal muscles to improve the posture. There's always a psychological evaluation in some of these kids. And before the new pectus system that is titanium, we used to have a stainless steel metal. So we used to test if there's doubt about metal allergies. If there's doubt of any genetic disorder, sometimes we send for a genetic evaluation to make sure we rule out one of these genetic disorders. and everybody gets a cardiac MRI so we can see how big is the aorta and make sure they don't have any aortic dilatation before we do the pectus repair. In the pre-op labs, like any other patient. Now, what are the main surgical indication and what is basically tell us what is the candidacy for the pectus repair is the Haller index. And the Haller index about 3.25, that's when we consider that is a good surgical candidate. Now, if the patient, sometimes the Haller index can be not that great when there's some of the asymmetry of the chest wall. And in those scenarios, is when we consider the compression of the heart, we consider other symptoms to evaluate the decision. But most likely the patient who has symptoms, who has even scoliosis, usually the Haller index is always above 3.2. One of the other signs is cardiac compression, and that's more when the adult population that maybe the Haller index is not that bad, but they can have cardiac compression and decrease the function of the heart. And this is how they do the Haller index is basically at the deepest point, the relationship between the anterior posterior and the lateral diameter of the chest wall. And also it's important when we evaluate this patient considering the chest wall asymmetry between the right side and the left side. And that's also give us an idea, how deep is the pectus excavatum, how we gonna repair. In that way, in our mind, we're considering if we're gonna use 2 bars, 1 bar, depends on what we do. The surgical procedure for any other pectus, we use the minimal invasive thoracoscopy. We start with the right side thoracoscopy to evaluate. We evaluate at that time the pectus excavatum. Once we evaluate, we start with the cryotherapy. It's the cryoablation for pain control. This is really a game changer in the management, the pectus excavatum, and decrease a lot of the pain post-op. The only problem is those patients have less pain and they start doing more physical activity, and we have more high rates to have moved the bars. So that's a consideration. But nowadays, I mean, there's no if there's no contraindication, everybody gets the cryoablation for pain control. The elevation maneuver, all the patients, we use the elevation maneuver. We usually use the rule track. And when we use the rule track, basically open the space in the mediastinum to create the window so we can placement of the bars. And we use all the time the elevation maneuver, because if you don't consider use the elevation maneuver, it's considered a malpractice at the time you operate on the pectus. Usually we dissect the window now with the peanut and use the graspers and the Maryland, and at the end we complete the window with the Lawrence bar. Once we pass the Lawrence bar, so we're still doing the remodeling maneuver with the Lawrence bar, and that's helped us to get a better position, reshape the chest wall. Now, when you start, before we using the rule track, this maneuver was very important. Most of the time now with the rule track is already doing the reshaping of the chest wall, but it's very important to keep doing the maneuver, compression the chest wall against elevating the patient with the Lawrence bar. And once the bar is placement, we proceed to flip the bar, correct the chest, and then start using the fixation of the bar on the lateral sides. For us, a standard of care is use the stitches, the Hammond stitches between the ribs and the bar to give more stabilization on the bar. And most of the time that, we do 2 bars. And when the pectus excavatum is probably the Haller index about 5. But it's a common practice nowadays. And we use the lateral holder on the fixation of the bar. That's the other indication. 1 bar, we always put 1 holder. If we have 2 bars, not all the time we use 2 holders. And what about the concomitant chest wall and aortic procedures? The reality, there's no much about this. Usually you can see it that in the big series of patients with aortic procedures, 6.9% of the patients went for a pectus repair. There's not much. Usually, is when you do the open procedure, it's like a modification between the ravage and the nose. It's like we usually still using at those patients the bar, and it's probably when you do open procedure, it's more easy to reposition the bar and fix the bar. The only tricky part is when you want to remove the bar down the road. Now, a lot of people recommend that they keep in this patient, they will keep longer the bar, usually between 3 years. So in this experience, you can see that the follow-up in this paper was like 30 months. They didn't have any pectus excavatum recurrence or bar displacement. There was only upper sternal depression was only reported in 7 patients. And basically because you lose a little bit of support, and those patients most likely needs to use one or two more than one bar, usually 2 bars. And one patient died for unrelated cardiac complications before removing the bar. So you can see this is the patients that we have. And this is one of the most reviews that you can find in the literature. And basically is they review all the data from 1953 to 2015, all the papers. And you can see that they have the most patients with connective tissue disorders in nose and pectus repair. And you can see there's 27 study. There's a total of 39 Marfan patients. The Haller index mean is around 9.2. And usually all these collagen tissue disorder patients, they have a higher Haller index. They only, you can see the concomitant aortic surgery and pectus repair only on 27 patients out of the 39. And the procedures were basically valve aortic root replacement. Only 15 of the 39, they have a valve sparing procedure. And only in 5 cases were emergency aortic dissection. So the surgical details were 29s have a median sternotomy. You can see like the cannulation were most likely femoral vessels and femoral artery and right atrium. Only one patient have a right axillary in the right atrium. And the chest repair was a modification between the ravage and a bar placement. And those are 16 out of 39 patients. The mean age between 28 years. And usually is where these Marfan kids are going for any of the procedures. So when we compare between stage and combined operations, this is the data that we have. And for our experience for the Children's Hospital of Pittsburgh with Pectus repair, over the last 10 years, we have a totally of 85 Pectus repair. These 85 that we did the repair, only 53 completed the bar removal so far. The mean Haller index is 5.2. The mean age that we do is around 16.6 years. And we only have 3 reoperations in 10 years for bar readjustment. Those the patient that one patient that had reoperated that was in my era in the last 5 years was a Marfan patient that was after 2 years was playing basketball, the bar moved. So what we did is basically remove one bar and keep the other bar in place to reshape it and complete the 3 years. And we have one patient with Loeys Dietz syndrome, one homocystinuria, and so far we don't have any other concomitant aortic procedures in a pectus. We only have one patient with a ASD and a pectus repair, but that was not a aortopathy procedure. In a few of the cases, this is a patient that has a Marfan that we did at Children's Hospital of Pittsburgh. You can see the severity of this pectus excavatum and important compression of the ventricle. That's the Haller index. The Haller index is in this kid is 7.2. And this is a patient that we did 2 bars. And you can see the result after the placement of the 2 bars. And this patient was before that we started 2 years ago the cryotherapy. This kid was before the cryotherapy, and this is the X-ray post-op, the procedure. Now this is the kid when after removing the bar, we can see the resolution. You can see that the patient still have a little bit or important asymmetry of the chest wall. I mean, you might argue that has a little bit of carinatum, but at the end of the pain, at the end of the patient feel much better. He feel comfortable. So at this point, we don't consider do nothing for this over fixation of the pectus excavatum. You can see the X-ray look pretty good. It's a little bit of asymmetry of the chest wall, but reality that's we got outcome. So this is how been our experience at Children's Hospital of Pittsburgh in the last 4 years that I've been doing the Pectus at Children's Hospital. And thank you for your attention. And I hope everybody enjoyed this meeting and hope to see you guys in person. Thank you.